Let's shine by seeing the best in all of us and by looking out for each other. Let's stay healthy. Let's shine together.
Hi, I'm Sherry Herlin, program host for Let's Talk Together. And today, join us, we are talking about gastroenterology, also known as GI. And we have two guests today from our gastro office, and we have Rachel Wilmot, our family nurse practitioner, along with Amanda Gibson, the other family nurse practitioner. Welcome, ladies.
Thank you.
Well, thank you.
And before we get started, we always like to find out how you came to Reid. And we're going to start with Rachel, because Rachel has a GO badge, which is of significance at Reid.
Yes, I've been there. It's going on 27 years. I started in the lab. I worked in the outpatient lab office, making phone calls and getting people scheduled for their lab draws while I was in nursing school. And then I went to the ICU and started there and worked there for almost 20 years. And I've been in gastro for, it'll be 6 years this July.
Mm-hmm. And Amanda?
So I started my career with Reid Health in 2018. And I started in GI in July of 19. Rachel and I both started the same time. Yeah, so it'll be almost 6 years in July.
Yeah.
No, great. And one of the things, what I was trying to learn exactly, what gastroenterologists specialize in the function and diseases of the digestive system. And you diagnose and treat a wide range of conditions, including ulcers, inflammatory bowel disease, colorectal cancer, and liver disease, like cirrhosis. So, and that you treat problems related to the GI tract, including I'm saying this wrong, dysphagia.
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 Difficulty swallowing.
And that's difficulty swallowing. Mm-hmm. And reflux disease, GERD, stomach ulcers, and issues with small and large intestines. And you also treat diseases of the liver, gallbladder, and pancreas. So one of the first things that we wanted to discuss was colorectal cancer. And so I'll let you guys decide who's going to speak first. But one of the first things is the epidemiology of colorectal cancer. So we have I think we have a slide that we're looking at. So if you can expound on our epidemiology.
I have trouble reading that. It's one of the most prevalent cancers. It is also one of the most, it's one of the few cancers that if found caught early, we can prevent it from happening. Colonoscopies are recommended starting at the age of 45. Colorectal cancer typically is not found in people younger than 40, but there are cases. And then depending on what is found in the colonoscopy, your screening colonoscopy will determine when your next colonoscopy will be. Removes polyps, looks for ulcerations, and anything else that might be going on in the GI large bowel.
And what are some of the risk factors? And once again, we have another slide that we will look at.
So there are risk factors that you can change and you cannot change.
Okay.
So in regarding to the risk factors that you can change, we have found that certain things, so obesity, that your risk of developing and dying from colorectal cancer is higher. And that link is actually stronger in men than women. It's stronger. Colorectal cancer is stronger in men than women altogether. Type 2 diabetes, higher level of insulin, diet high in red processed meats, that also increases your colorectal risk. Actually, we found this one very interesting, low vitamin D level. Cooking meats at high temperature creates chemicals that might raise your risk for cancer. Smoking and alcohol use also increase your risk of colorectal cancer. The risk factors that you cannot change is obviously your age, your racial and ethnic background, your sex. We've seen, from the evidence that we've looked at, having your gallbladder removed also is a risk factor. Your personal history of colorectal polyps or family history of colorectal cancer, you can't change that. You can't change your risk of your inflammatory bowel disease. I mean, that's something that you have, autoimmune disease, so you can't change that. If you've had personal history of radiation to the abdomen or the pelvis area, that can also increase your risk, and that's something that you can't change. I think I've already said the history of the polyps as well, and having an inherited syndrome, so something like Lynch syndrome, polyposis, those things also something that you can't change, the risk factors that put you at a higher risk for colorectal cancer.
Interesting when you were naming some of the risk, when you were saying temperature, cooking something food at high temperatures, made me think, and then red meat. So I'm thinking of men grilling.
Yeah,
Does that have something to do with some of the?
I think it's just the
chemical.
Yeah, we
the
were
chemicals.
looking further into this because it also was very, informing to us as well when we were looking into it. But yeah, it was something with the high temperatures and how it changes the chemicals or with the food and how we digest it. And
Yeah. And
I'm sure there's a lot more that goes into that and can be defined further, but yeah.
And then some of the symptoms that you'll see.
So usually,
I can do it.
Okay.
Okay.
Change in bowel habits is a big one. If you typically have normal, regular bowel movements and suddenly you have diarrhea or constipation, that can be a risk factor. Rectal bleeding or bleeding in your stool. Black tarry stools is another indicator. Abdominal discomfort. Feeling like you haven't completely evacuated your bowels when you have a bowel movement. Feeling tired or weak. And then unintentional weight loss is another one.
And anytime you see bleeding in places you don't normally see it, that's always a sign
that something's going on. Yes.
Or if you have like a abnormal stool caliber, like pencil-like people, that's also an indication that we need to do, to evaluate for colorectal cancer.
And then we look into the testing.
Yes.
And our next slide was talking on some of the testing, what people are you're looking at.
So, do you want to take this one?
Sure.
There are actually many different testing modalities that can be done, and the number one recommended testing is obviously a colonoscopy. Colonoscopy is the standard, the gold standard, and it all depends. And also, colonoscopy also depends on, you have to have a really good prep because we got to be able to see anything. If you have a poor prep, then you're not able to see everything that we can around folds. So colonoscopies start at age 45, sometimes prior to that. Depending on your family history of colorectal cancer, it could be sooner, but it also depends on your insurance. There's also Cologuard. So a lot of people use Cologuard. And this is from usually, recommended screening is from 45 to 75. After that, if they've had normal colonoscopies, they don't have to have a screening colonoscopy after that. But so in regards to the Cologuard, this looks at DNA shedding and blood in your stool. It either gives you a negative or a positive result. And you don't know if it's more blood or more DNA shed. So then what happens after that is that then you end up needing a colonoscopy. So, the sensitivity of these are not as high as obviously a colonoscopy. There are false positives, there are false negatives. Also, these are done every 3 years, but sometimes these are used, wrong. So if you have a family history of colon cancer, if you have a family history of adenomas, if you have a personal history of polyps yourself, you should not be doing a Cologuard. And a Cologuard should not be done for anyone after 75. There's also other fecal tests. So there's a FIT test, but this FIT test is done and it looks for lower GI bleeding. So, but these tests also depends on what you eat, the medications you take. So if these things are ate or the medications you're taking before it can cause a false positive test as well. The biggest test that we see other than the Cologuard is the FOBT, fecal occult blood test. So this shows blood anywhere from the upper or lower digestive tract. So we can't tell if it's upper or lower, but it comes back positive. Also, the medication that you take also has an effect on the result of the outcome of that test.
Hemorrhoids can
And we
also
have a
affect
slide
that.
on that's sharing about the Cologuard and some of the pros and cons.
Yeah. I mean, a lot of people like doing the Cologuard because it's more, send off a stool sample instead of doing the whole prep, because a lot of people don't like the prep for the colonoscopy.
That's something let's talk about the prep for a colonoscopy.
There are several preps. We pick one depending on medical history, whether you have kidney disease or other risk factors. Typically, we use Miralax and Dugalax prep. You basically take some pills and you drink a bottle of Miralax with some Gatorade, and it cleans out your system, so then the physician can see the inside of the colon much better.
And you'll need to be at home.
Yes, you need to be at home. Yes,
That's the worst part.
Usually starts in the afternoon, evening, the day before.
Yeah.
And then the colonoscopies the next day, and then people tend to go back to work the following day after your colonoscopy. So
I've had 2. So
Yeah. There are different
they're
preps.
different.
And it also
Yeah.
depends if you have a history of constipation, then we probably need to give you more prep, because the worst thing is someone goes in for a screening colonoscopy and they're told they have to come back the next day
can't
or another
imagine.
time because they're not cleaned
Cleaned
out.
out, yes.
So, yeah, we take that into effect as well. Yep.
yeah, I remember the first one I had about in the evening, the early evening. But then the second one, I was getting nervous, and then like later in that evening, I
kinda hits
had a
you,
great
yeah.
friend in the bathroom. So.
Yes, yes,
So that's the
That's the worst thing until we can figure out another way.
yeah, yes.
that you have just getting that. So it's always when you ask people what's the hardest thing about a colonoscopy,
It's the prep.
It's
Prep.
It's the prep. People do, patients, they do really kind of freak out that someone's going to be in their personal space.
Yeah.
I think that's another thing. And, when I reassure them that, how the procedure goes, and then they come back and they see me and we go over results and they're like, that wasn't bad at all. Like, I was freaking out for nothing. So,
Yep.
but again, the worst part is the prep. Yeah.
And actually, once you get into the office and you don't even realize it. Well, I remember the last thing you're talking, and then I was back in the.
Yeah.
Yeah, you were done.
I was done. I was in recovery.
Yeah.
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 Yes. A colonoscopy itself, screening colonoscopy, takes about 10 minutes or more.
Depending on what they
depending
find.
on if you have a lot of polyps or something else that's found during that time. So it depends. But if you normal colon, nothing, no polyps or anything, and it's smooth going, and it's about 10 minutes. So
It's
people
a-
are shocked how fast
Yes.
it's gone. You're there an hour before. That's the longest time you probably spend there.
It
is
takes
getting
longer
there.
to get you ready for the test than it does to actually
Right.
do the procedure.
Yeah.
So
And then you always have the best between the nurse practitioners, the physicians, and all of the support staff is just amazing. So
Yeah, we have you have to have a good relationship. We work really close with Rose staff, the outpatient endoscopy, and they're all great. We have a really good relationship with them, work closely with them, and all those girls, they're wonderful. They are, and they keep the patients comfortable. Dr. Raza, the physician, and Dr. Latour is the anesthesiologist, and so nothing but good things when patients come back from their experience. So that's good. That's what we expect.
And back on the, I think we've done with the screening of the colonoscopy and the color guard.
Yeah, the color guard.
We look at one of the things that I've been in another conversation, and the a person said, "Well, you know that the UPS guys knows that box," and so you can't. I never looked at it that way.
Well, they can be dropped off, I think, a lot of places, but my patients do tell me that. Like, they're worried. They're like, they know what I'm walking in with in this box. Like, yeah, I have someone told me, like, I was waiting for another person to walk in. They had the same box, so I walked in with my box. Like, they were waiting.
So if you're shy sometimes, that's when half the room said, I'll just get the, no, I won't do that. I'll just stick with going for the procedure.
So I think it's, I mean, again, I tell a lot of people do the Cologuard, but I think also when I talk to them, like, well, with your family risk or you've had polyps. If you've ever had polyps at a colonoscopy, you should not do a Cologuard. That's not something you should do every 3. You need to have a colonoscopy. So and I don't think patients realize that. So, but that's why we're there to educate them on this regarding that.
And so when they're deciding and scheduling it, they are notified if you've had those polyps or.
Yeah, after. Sorry, Rachel.
Oh, it's okay. Yes, if you have a history of colon polyps, the Cologuard is not the appropriate test to proceed with. It will give a false positive generally, and you have to have a colonoscopy anyway if you have a false positive, or a positive result at all. But yes, depending on the type of polyp, the size of the polyp, will determine when you return for your next colonoscopy.
Another on the fecal occult blood test. If you can expand on that, I think we also have a slide.
Yeah. So a lot of times this is used as modality for. So technically this can be used, not just one, it needs to be multiple, but this is used a lot for patients and especially in the hospital setting, if they're having, but there are things. So yes, it's stool-based. It can be done at home. There's no prep for it. There's no risk, but again, this gives you a positive or a negative. And again, we don't know if it comes back positive. We don't know if it's from the upper GI or the lower GI, meaning if it's, gastric, small bowel, or large bowel.
Or hemorrhoidal.
So hemorrhoidal. So if you have hemorrhoids, this can also cause a false or a positive test, and then this positive test then will come back and you'll need a colonoscopy after that. And a lot of times we've seen this. The positive fecal occult blood test is due probably more than likely from their hemorrhoids because nothing else was found within the large bowel. So this one is also I would not use that as a screening modality. A lot of people, especially primary care, I'm sure they're just trying to get these patients just to do something to evaluate for that. But I've seen it's used a lot more inpatient. I mean, they do use it outpatient too, but usually when these come back positive through the referral, then we do send them on for a colonoscopy because you have to evaluate if they have bleeding. We don't know if it's hemorrhoidal or something else, polyp that needs to be evaluated.
And the other test is the fecal immunochemical test.
Yeah, that's the FIT test.
Okay.
So that one, it's also a stool test, but this one only detects for lower GI bleeding. We see it once in a while. We do not use this. I mean, what we use is colonoscopy. Some primary care providers use this test along with the FOBT as part of the screening, but again, it's sending your stool off to the lab. So, and it detects for lower GI bleeding for this FIT test. And these are things that are like something in blood that you can't see, physically see, but they can see it through this test.
And then might throw you off here a little.
That's
but
okay.
If a person knows they're of that age and it's time to get their colonoscopy, so what would be the steps?
Give me a call.
Yeah.
Just kidding.
Yeah. Usually it requires a referral from primary care.
Okay.
I think all of them require, but
Yeah.
they get,
Yes.
you don't necessarily have to have an office visit prior to a screening colonoscopy. You can go directly to the colonoscopy. We follow up then with results, and depending on the results, you may need an office visit or not. And then we tell you when to repeat the test, which is important for follow-up.
And
follow up on the
approximately
post.
how long does it usually take to get scheduled, or?
Oh gosh, I always say that schedule kind of varies on a hourly
does.
basis. It really
Sometimes
does.
I'm to jump in to say, often if we do a lot of community things and people are hearing more about it, then like a group of people might decide, I think I need my colonoscopy
Yes,
because I've learned
yes,
that. So.
yes.
Well, a lot of people feel they need that when it comes closer to the end of the year.
Yes.
Oh, okay.
Yes,
You got to
meeting
get
their
it in before the end of the year.
meeting their
Yeah.
deductible.
Yeah.
Yeah.
But yeah, referral.
Yes, need a referral. And like I said, you don't always have to have an office visit. There are certain things that would require you to have an office visit. If you have a history of inflammatory bowel disease such as Crohn's or ulcerative colitis over the age of 80. What are the other that require you to have an office visit?
Oxygen requirements.
Oxygen requirements
But-
or cardiac history. Cardiac
Okay.
history is another
Yes.
one. If you have a significant cardiac history, we want to evaluate you before we put you under sedation.
Yeah. The anesthesia risk.
And then the results?
The results
Usually?
typically are pathology, which is the biopsies that are sent off. They look at them, the pathologist looks at them underneath the microscope, and those come back within, a week or so. We typically will call. We always call. Somebody from the office will call, and then depending on those results, we'll determine the next steps. If it's, repeat colonoscopy in 5 years and everything's okay, or you need to come into the office to talk about something else that might be found on the colonoscopy, such as microscopic colitis, which is inflammation that can only be seen underneath the microscope, that needs to be treated with medication. So,
Well, I ask
Okay.
this to both of you. So what's one thing you'd like every patient to know? So who gets first?
screening colonoscopies are very important. Very important. They can actually, determine colon cancer early. If we find a polyp that is cancer, we can actually remove it right then and there. They're just so important. They're just like mammograms for women. They need to be done on a timely basis, and you need to start them at the age of 45 because we are finding colon cancer in younger and younger populations. So,
Amanda.
What should patients know? Well, Rachel's already hit the colon cancer screening. I want patients to know that not to be afraid to come to the appointments. We are very, I feel like we're easy to talk to, and a lot of people don't want to discuss their problems. I mean, their personable problems, right? We're respectful and we listen and we truly care, and we want them to feel that way. If they don't come to their appointments or they're scared about the colonoscopy, the screening, or the prepping, call the office. We'll talk to you because it is an important part of the screening process for them. And what else? I told Rachel this. I said, tell every patient to bring an updated medication list to their appointment.
Yes. Yes. Medications they play a huge role. I mean, if you're on a bunch of heart medications, we need to know those. Lung issues, on inhalers and things like that. So, that plays a big role in the liver too. We need to know what medications you're on for livers. So.
And we have a slide on, here you are.
Look at us.
On our providers. Dr. Raza,
Yes.
being startled. And, So how could, and we want our community to know, these wonderful smiling faces would always be to help, as well as how to contact your office. Would they just call after they get the referral? Do they call the person or central scheduling?
Getting the referral.
Yeah, you have to get the referral, and then there's a review process.
Not everyone goes.
Well, that's true.
With the central call center, they're getting more and more people in for their appointments. But if they haven't heard from the referral, if our office hasn't contacted them within a week, I tell them to reach out to our office and to check on the referral.
Check on the status of it.
Yep, and see if they can be scheduled.
Well, great. Well, as we come to an end, I want to thank both you, Rachel and Amanda, for joining us today on Let's Talk Together.
Thank you.
Yes,
And
thanks for
thank
having
you
us.
for joining us on Let's Talk Together.
Let's shine by seeing the best in all of us and by treating you here, right in your hometown. Let's look out for each other. Let's stay healthy. Let's shine together.